This week, there are two papers about long COVID. One gets all the attention, all the uproar. That's the paper in MMWR. The better paper in the Annals of Internal Medicine, crickets. It's crickets. Let's talk about these two papers. Let's run through them, see what they show and what they don't show. Now, of course, long COVID is something that's incredibly important and obviously very real to those who suffer from it. Long COVID are symptoms, signs, concerns that occur after a diagnosis of COVID-19 that may persist for a long period of time. What exactly is the cause of long COVID? How frequently does it occur? What can we do about it? These are important questions that we yet don't know the answer to. It is clear, however, that evoking the term long COVID has policy implications. There are many people who choose to evoke the term because they favor continued restrictions to prevent the virus from spreading, because that will mean fewer cases of long COVID, and less long COVID the better. That's the argument. There are other people who contend, and I'm in this camp, that this is a virus that's so transmissible, there are no NPIs that can hold it at bay forever. The vaccine does not have a long-term durable vaccine effectiveness against any symptomatic disease. It has much better protection against severe disease for a while, but it doesn't have long-term durable protection against any symptomatic disease, and as such, it's incapable of halting transmission. And when those things are true, highly transmissible, the vaccine incapable of halting transmission, you will get something in the ballpark of 93 to 98% penetration in the population, no matter what you do. And so I argue that insofar as long COVID is a problem and a concern, it's a problem and concern we're going to have to deal with in the short term. And insofar as long COVID is exaggerated or distorted, it is something that, that requires better scientific study. But long COVID in and of itself does not wed yourself to any policy prescription. But what is long COVID? How often does it occur? We have two rival papers that came out this week. One got a lot of attention, one didn't. Let me run through you those papers. The paper from the Annals of Internal Medicine, this is the brilliant paper. It's a longitudinal study of COVID-19 sequelae and immunity baseline findings. This is from the National Institutes of Health. And it's a very simple and straightforward study. They take a bunch of people who have had COVID, and it is enriched with people who are suffering from post-acute COVID symptoms or long COVID symptoms. In fact, 55% of the patients in that arm, 189 people, had those symptoms. And everybody in this, 159 had a antibody positive against nucleocapsid, which is not in the vaccine. Okay, these people had to have been infected with the virus to have this antibody. And the rest of them didn't have that antibody on baseline visit, but some of them had that antibody and lost it, which is very interesting because it actually tells you that that antibody doesn't tell you the total number of people who've had COVID-19. It has implications for seroprevalence. Seroprevalence was probably an underestimate. It's likely to be down by maybe 15 percentage points. And then some people had a PCR positive COVID-19 test, but they didn't have that antibody. So again, that's about 30 out of the 189 people. So I think it's about whatever percentages you get from the CDC as to seroprevalence, maybe bump it up about 15%. That's probably the real seroprevalence. And bump it up a little bit higher because a lot of those estimates are pre-Omicron, and Omicron just blew through the population. Back to this paper. They take the 109 people. They have definitely had COVID. They definitely have COVID. There's no doubt about that. They have had COVID. Many of them have had these long COVID symptoms. They're enriched for that. That's probably why they're choosing to sign up for this study. And they find a set of controls, I think about 120 controls. It's harder to accrue controls because, you're a healthy person, you feel fine, you never had COVID. Are you going to subject yourself to a battery of tests? 120 people did, but they're accruing a little bit slower on that arm. Fair enough. They then perform a battery of tests. And I mean, they literally just say, run all these tests. And here's what they run. Okay. C-reactive protein, D-dimer, cardiovascular markers like troponin I, pro-BNP, neurofilament light chains, renal markers, hepatic markers, hematopoietic markers. They even do, in some subgroups, flow cytometry on T cells. They do all of the rheumatologic things you could think about. They do things including interferon gamma, tumor necrosis alpha, PD-L1, interferon-induced protein, interleukin-2 receptor alpha, interleukin-1b, interleukin-6, blah, 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 blah. They're doing everything. Granzyme B. My favorite Granzyme B, but of course, okay. They're running all these tests. They're also doing PFTs, pulmonary function tests. They're doing echocardiograms on these people. And here's the question. We've got a group of people enriched for long COVID. These are people who've had COVID, that's for sure. They're suffering in a very high amount, 55%, are suffering from long COVID symptoms. That's probably, that is not just probably, it's definitely way higher than the average population, because we know that, 140 million Americans minimum have had COVID-19, maybe even higher. And we also know that 55% of them don't have long COVID, so it's something lower than that. But when you take a group that's enriched with long COVID and you take a group of people that definitely didn't have COVID, and you compare the two, you can ask yourself, which of these things is perturbed or abnormal in long COVID? So it's, I think, really clever. Now, and here's what they find. In the physical examination, pretty much the only thing that was more common in physical exam findings was more tendinitis. But again, tendinitis is, pain when you palpate a tendon. It's a subjective thing. Plasma levels of C-reactive protein, D-dimer, biomarkers, troponin I, proBNP, brain injury, neurofilament testing, they did not differ. Renal markers, hepatic markers, hematopoietic function markers, no differences between the groups. Anti-nuclear antibodies, rheumatoid factor, anticardiolipin antibodies did not differ. Coagulation factors did not differ. PFTs, the same. Abnormal findings on TTE occurred in both groups at the same rate. The group that had long COVID symptoms, the group that had COVID, they have a lower 6-minute walk time. But again, that's a subjective endpoint because it's based on how much you can walk in 6 minutes. The only two things that predicted whether or not somebody had the post-acute COVID symptoms or the quote-unquote long COVID symptoms was being of the female gender and a prior history of anxiety disorder. There were no significant differences in all of those inflammatory proteins, interferon gamma, TNF, interleukin-1 beta, interleukin-6, interleukin-8, CD40, the T-cell flow cytometry, identical. Only granzyme B was different. But when granzyme B was different, if you looked within the group of people that had COVID, those that had those long COVID symptoms, those that hadn't, there was no difference between that group. So even granzyme B, didn't really explain why some people are having persistent symptoms. So what are we to make of this study? It's a brilliant study. They're taking a bunch of people who definitely had COVID, enriched for people with long COVID, and they're asking pretty much by every sort of rough metric of biological function, can we find something that identifies these people? The idea is that COVID triggers a continued immune response in the body. Your body continues to fight COVID. Maybe there's still COVID there doing some damage. Your inflammation is more. Your coagulation is distorted. And yet, by every single test they're running, they cannot find evidence for any of those claims. So what is long COVID? I guess I would say this is not the final verdict on it, but this suggests that if it is in fact something that is mediated through the cascades of thrombosis, coagulation, hematopoiesis, pulmonary function, cardiovascular, neurologic, it would have to go through a pathway that is not captured by any of these lab tests. It's really got to be quite something for it to be that way. If it is something that is very real and a very real type of suffering, because anybody who's suffering, that's real to the person who's suffering. There's no doubt about that. And it needs to be taken very seriously, and it needs real treatments. It needs treatments that make that person better or make people like that person much better. Absolutely. But to the extent that that is caused by perhaps underlying anxiety disorder, perhaps the constant suggestion in the media that long COVID is a great boogeyman that we must fear at every turn, the constant priming by the media, I think that's something that needs to be taken seriously. And one way to tease that out would be to compare rates of long COVID in the United States, where we are bombarded by a media that likes to talk about it. In fact, a media that invented it, because perhaps it was invented in the Atlantic article by Ed Yong. Prior to that, I never heard of it. The media does a lot to talk about it. What about in countries where they don't have that media presence? Do you get the same rates of post-COVID symptoms? None of this is to say that we shouldn't take very seriously these concerns. We should. Anybody who comes to the doctor's office with any concern must be taken very seriously. But how do you make such a person better? And I've been the early proponent in November of 2020. I wrote, you need to run large-scale randomized controlled trials in people with the long COVID syndrome. You need to run those randomized trials, and you need to try different things. If you want, you can try a blood thinner. You could try it, sure. We don't have any evidence here that would make me go in that direction. If you want, you can try a statin. If you want, you can try Plavix. But again, we don't have any evidence here that those would be the pathways you need to hit. Lipid pathway, antiplatelet pathway, anticoagulation pathway. We don't have evidence that those are the pathways you want to hit. If you want to try something else, something that works for things like perhaps neuropathic pain or anxiety disorder, things like an SSRI or SNRI, I think it's worth trying, and it needs to be done on a large-scale effort. And I think that's what this paper suggests. It's giving you some clues. What are the pathways you're going to target when you try to make people better off? Of course, in well-done randomized controlled trials. I think they have to be double-blind. They've definitely got to be double-blind. I think it also means that these clinics that are opening up at every hospital where they're trying to take somebody with long COVID and do a battery of tests, we need to demonstrate that you are likely to find things in those tests beyond what you would find in age sex match controls that didn't have COVID. And if you don't find anything beyond that, do not pass go. That strategy is not unlikely to benefit that person. And even if you do find things beyond that, you need to do sort of randomized controlled trials of the testing strategy to show that the testing strategy finds things that make people better off, feel better. And of course, quality of life is lower in the group that had COVID and suffering from long COVID symptoms. Of course, the 6-minute walk test is lower. And of course, they're having a little bit more tendinitis on physical examination. So they are suffering. There's no doubt about that. They're not walking as fast. But what is the pathway that's implicated? That's the question. And this paper, I think, brilliantly done, gives us a lot of things that might not be the case. The next paper, post-COVID conditions among adult COVID-19 survivors aged 18 to 64 and 65 and up, United States, March 2020 to November 21. This is MMWR, the CDC's journal, their journal. It's only a rag because they only publish, what are they trying to do? They're trying to publish the worst science I've ever seen is in an MMWR. They're going to do whole classes in epidemiology about, if you want to do lousy epidemiology, where are some examples of lousy studies? Oh, here's the 2021 edition of MMWR. You can have some gold mine of studies, bad mask studies, etc. Okay, I gotta say, well, why do these bad studies happen? Anything in science where everyone has decided there is a right answer and it's a virtuous answer is an issue in science. You're never going to get good science. If you decide that cloth masking toddlers is the right answer and it's the virtuous answer, so good people do, you decide that, then I guarantee you can do some garbage retrospective study that will prove your conclusion to be true. There are so many data sets you could look at. There's 10 to the power of 5, 10 to the power of 6 different data sets you could look at. And then there's 10 to the power of 8 different ways you can analyze the data. What covariates are you going to put there? And when you give somebody who knows the right answer and the virtuous answer 10 to the power of 8 or 10 to the power of 9 ways they could analyze the data, and you let them pick the way they want to show you, of course, they're going to find the right way. And it's even worse than that. Even if they don't succeed, there's so many different people looking at the question. Somebody's going to yield the right answer, the quote-unquote right answer. And the net result is the literature is not truth, but rather a self-fulfilling prophecy or an opinion poll, and little better than that. So back to this paper. This is a paper that the CDC is trumpeting, and they are literally tweeting that 1 in 5 people who have COVID have a long-term condition. What are the problems with this paper? They're taking people who present to an EHR facility with a COVID-19 diagnosis and comparing them who present to a EHR, electronic health record facility, I think in the same month, if I recall correctly, who didn't have a COVID-19 diagnosis. And they're following them in the future and looking at something like one of 26 different things that have been implicated in the long COVID syndrome and asking how much more of that do they have. And they have a roughly, 1 in 5 increased risk of one of those conditions. And that's where they get the 1 in 5 number. There's a 1 in 5 chance you're likely to have something in one group than not in the other group. That's the excess burden of these conditions. That's what they're saying. What's the problem with this study? Well, they're saying that of all the people who have COVID, 1 in 5 have a condition that might be attributable to having COVID. They're making the causal claim. But as you know, what percent of people who have had and recovered from COVID went to the doctor and presented to one of these departments and got swabbed there and had it documented in the system? It has to be the paucity of people. Most people who have tested positive for COVID, especially recently, you test at home. You find, to be honest, first of all, many people don't test at all. They just had the, quote, worst sore throat of my life after my 3 shots. I had the worst sore throat of my life. It lasted a long time. It was right at the peak of Omicron. Probably was Omicron. I didn't test. Or I tested at home. It was positive. I laid in bed, tried not to swallow saliva. People like to say, sprayed myself with chloroseptic spray until my whole mouth went numb. And I didn't go in and get tested. The people who are going in to get tested, they're the people who are the most worried. They have underlying medical conditions. They feel very vulnerable. They feel very sick. They're going in and getting tested. Also, the COVID-19 virus, it doesn't just strike people at random. It does have things it zeroes in on. It zeroes in on age, but it also zeroes in on socioeconomic status and racial makeup and obesity. I mean, it zeroes in on factors that themselves may be tied to markers of socioeconomic disadvantage in the world, and also things, unfortunately, that lead to poor health. And so somebody on the margin who gets sick with COVID and goes in to get tested in these facility is not going to be the average person sick with COVID. They're probably going to be the sickest person sick with COVID. And they compare that to somebody who came in for a different reason. They actually say they don't match based on sex, race, ethnicity, healthcare entity, or geographic region because data were not available or were inconsistent. They're not even matching based on like basic covariates. What are you doing? They're matching 5-1. Okay. And then they're looking to see the increased rate of this diagnosis of these diagnoses. The other problem they suffer from is once someone says, I have COVID, I've had COVID, I've recovered from COVID, and they come into the doctor and they say, I feel, insert the thing, I feel a little short of breath, I feel a little lightheaded, I feel a little, the doctor may run more tests on that person or may attach more labels to the chart than if the person came in 5 years ago, said I had influenza and I still have these symptoms. They may not have run the same tests. And certainly a person who comes in and for a different reason, they're not running the same tests. The more you test someone, the more you find things. There's an old saying in medicine, show me a healthy person, I'll show you someone who hasn't had enough tests. So this study compares people to other people who are, first of all, let me put it this way. This study takes a fraction of people with COVID-19, perhaps the sickest and worst off people, and they compare them to different people who didn't have COVID-19, but may not be at all comparable in any way, shape, or form, and asks what percent or what are the rates with which these two groups have subsequent diagnoses that are one of these 26, long COVID diagnoses, when those diagnoses are not equally ascertained and not equally documented, not equally pursued. What am I to think when I read this? I just think it's so useless. It's the most useless thing I've ever seen. It's just garbage. I mean, if you want to know that people, what are the rates people have it? I mean, I think you got to get something close to the NIH study, or you got to at least have some more granularity in who you're matching. And I told somebody this. When you look at this kind of very high level data, and you take a condition that preys upon socioeconomic vulnerabilities, on underlying health status, on age, on race, that's what COVID preyed upon. I mean, there are groups of people that disproportionately suffer from COVID-19. And you want to know, what did the COVID-19 do to their health in the future that didn't already get done by all those sort of disadvantages that we have tolerated in this society, which I believe are unfair and unjust and need to be remedied? But what did the COVID-19 do beyond that? You need to compare that group to people that is otherwise comparable that just didn't get that COVID-19. And that's not so easy. It's not so easy in this kind of large-scale data set. You get a lot of sample size in your study, but, if you put a lot of garbage together, it doesn't make it good. It makes it a landfill. And that's what this study is, just a landfill. Just garbage. I mean, I don't even know what to say. I mean, there are people I know who are professors of medicine, and they're texting me that this is literally misinformation. I mean, the quality of the science is so poor. What are we to call it? We're calling it like it's like intentionally wrong information, but it's put forth by the CDC. And I think this is why, I disagree that we need to be in the information policing business. But I certainly think that the people who want to police information, if they themselves are the major contributor of misinformation, it doesn't really make me feel good that the person saying all the wrong stuff is the one that says, I'm the one who's going to tell you what's right to say. What are you doing? What are you doing? And so that's the problem with this paper. So 2 papers on long COVID. They're very different papers. One is very, very good. One is very, very bad. One tells you a lot. One tells you nothing. But one is the right answer. It's the right answer. The right answer is that COVID's so bad that 1 in 5 people have a condition from COVID. That's the right answer. And that's why a lot of doctors are going to tweet it and a lot of scientists are going to tweet it. It's the right answer. It's the right answer. And that's why we have to stop COVID-19 spread. That's the right answer. Right answer is the virtuous answer. And the moment science becomes virtue, they will find what they want and their brains are going to turn off. The other study, it's not the right answer. It's the wrong answer. The wrong answer that this is something that of all this battery of tests, the things that shake out, female gender, underlying anxiety disorder, it's a wrong answer. It doesn't sound right, Perhaps somebody might misinterpret that answer to mean that this isn't real suffering. That's a misinterpretation of that answer, but perhaps somebody will make that misinterpretation. Perhaps somebody might misinterpret this to mean that, it's not quote unquote organic or sort of these kinds of pejorative things people have said. I think that's misinterpretation. Whatever it is that makes people suffer, that suffering is real. I mean, it certainly is. Anyone who struggled with any issue where it is very difficult to point your finger at the biochemical pathway implicated, but nevertheless has felt misery from it, and depression's a great example. The question isn't, what is the exact molecular mechanism? The question is, like, if you do a randomized trial of people who are suffering from depression, you give them SSRI or not, do they feel better? And then I think there's some key question you got to answer, which is like, is the control pill, is it going to be a pure placebo pill, or should it be a pill that gives the same metallic taste as the potentially the candidate drug? Should it be an active placebo so you can kind of separate the potential neurocognitive effect from that some fraction of participants will unmask themselves and know that they are in fact getting the active agent? You need to separate those two things so you can do these well-done studies. So this animal study is very useful for long COVID. It suggests that, I would be reluctant to do a randomized trial of rivaroxaban. I would be very pro doing a randomized trial of mirtazapine. That's how I would think about it from the pathways that have been implicated in this thing. That's very useful information. And if a randomized controlled trial of mirtazapine is successful, i.e. people feel better, then of course it should be covered by insurance companies and people should get access to that medication. Of course, if they give it and if they feel better, yes. But if you do a randomized controlled trial of Lyrica and it doesn't work, then of course doctors shouldn't prescribe it. But you need large, robust, randomized controlled trials. And if you do a randomized controlled trial of 1,000 people with long COVID, and in one arm you get the test special, you get an MRI and whatever, echo and this, that, and the other, and you show me that 3 years later or 5 years later they're both living longer and have better quality of life scores, I'm going to say everybody should get that battery of tests. But if they're not living longer and they're not living better and they just have more diagnostic labels, I'm going to say you wasted our money and you medicalized them and they didn't need that extra medicalization. So randomization is the solution here. 2 good papers. One, talk of the town. It's the right answer. It's the virtuous answer. It's the answer that, a lot of people in media have already decided is the right answer. The other studies, just, a tough pill to swallow. But that's science. And if you approach something in science, you've got to be an honest actor. You don't know what you're going to get. If you approach the COVID-19 question with, I myself, I think there's a lot of commenters, I myself am anxious. I haven't gotten COVID, at least that I know of. I don't want to. I'm not talking about me. I'm talking about them. But I also have. But okay, I'm talking about them. I don't want to risk being out there with people who are unmasked. If you feel that way, then it's so easy to concoct in your mind that what justifies that? Well, I've been vaccinated twice and 3 times and maybe even the 4th dose. What justifies my feeling that I need these precautions to continue? And then you say it's long COVID. It's very frequent. It happens to everybody. It's really problematic. We have to minimize it, and that's why we have to continue to do this. And then somebody says, well, we're all going to get COVID anyway. And you say, well, that's fatalist. That's wrong. That's a mistake. But I mean, you twist all the logic around to get to what you want, which is the thing that makes you feel better. But that's not how science works. You have to pull it all back, see the world as it is in unflinching honesty, and then think about what policy might try to make it better, and then realize in the grand scheme of humans trying to make their world better, can often make it worse. Policy doesn't always work as well as you think. People don't always adhere to it as well as you want. And there are all these things that happen along the way. So that's what you get on this channel. Policy analysis, 2 COVID papers. One's good, one's a landfill. It's this collection of garbage together that creates a landfill. And that's within a broader landfill / toxic dump, which I call MMWR. And the other one is the Annals of Internal Medicine. It's a really good paper. So those are my thoughts. You know what to do if you like this video. Like, comment, subscribe, recommend it to a friend, leave a message. Until next time.